Hello and welcome to my channel. In this lecture we'll be discussing the urinary organs. So let's begin. The urinary organs are the two kidneys and the two ureters that open into a single reservoir for urine, which is the urinary bladder, and the urethra for emptying of the bladder. In this lecture, we'll be discussing the kidney, not the collecting system, which will be in the next lecture. Kidneys, they don't only have the function of excretion of urine, they have an endocrine function because they secrete erythropoietin, which stimulates the production of RBCs, secretes renin, that's involved in the renin-angiotensin or angiotensinogen present in the lungs for the control of the blood pressure, and the secretion of the 125 dihydroxycholecalciferol involved in the metabolism of vitamin D and calcium metabolism. So it's not only the excretion of urine function for the kidneys. They are present on the posterior abdominal wall, as you can see here in this plate and this specimen cadaver. They don't lie flat on the posterior abdominal wall but tilted, so the transverse axis is directed posterolateral and the longitudinal axis is directed infralateral, so slightly oblique as they go down and oblique as they go backwards to the posterior border of the kidney, as you can see here, because of the sides, the protrusion of the sides of the vertebral column. That's why they assume this rather tilted position. The transpyloric line passes through the upper part of the hilum of the right kidney and lower part of the hilum of the left kidney, means that the right kidney is slightly lower than the left kidney, as you can observe here. The lower pole is at a lower level than this one because of the heavy liver above the kidney pushing it down. So don't forget this. The upper pole for individual kidneys, the upper pole is bigger or broader than the lower pole. See, the lower pole is slightly pointed. It has a lateral border. Sometimes it's lobulated, obvious lobulations present at the border, and a medial hilum. See, this is the hilum of the kidney, and hilum where structures enter the kidney or come out of the kidney. And the hilum extends inside the substance of the kidney for a distance called the renal sinus. So since it's deep, so it has an anterior and posterior lips. The arrangement of the structures at the hilum of the kidney, the renal vein anterior, and the artery in between, and the pelvis posterior. So this is a posterior surface of a kidney, and if you think about it, this will be the left kidney. If you flip it, it will fit on the left side. Don't forget this arrangement, please. And don't also get confused, because and most of the times a branch from the anterior division or the renal artery itself comes posterior to the pelvis of the ureter or renal pelvis, but the main structure, the main artery, is still in the middle between the vein and the pelvis of the ureter. The relations, the anterior relations of the kidneys, on the right side, see, the second part of the duodenum crosses or covers the hilum of the right kidney, and most of its anterior surface is related to the liver. Remember the impression, renal impression on the right lobe of the liver, on the posterior-inferior surface. And remember the fact that also the right colic flexure is on the lower pole of the right kidney. Don't forget that. So the anterior relation of the right kidney is the duodenum and most of the surface to the liver, and the lower part is related also to the right colic flexure. On the left side, In this plate, it's not accurate because the upper pole of the right kidney with the suprarenal are related to the stomach. It's part of the stomach bed. Remember that? It was shown in the stomach bed. And the pancreas actually crosses the hilum of the left kidney. So it's not that high. It crosses the hilum of the left kidney. And at the lower part, there are coils of jejunum here, not the left colic flexure, because the left colic flexure is on the left side of the kidney, related to its left border. Remember these facts, please. Left colic flexure is on the left side of the left kidney, while the right colic flexure is on the lower pole of the right kidney. And of course, the kidney has an impression on the spleen, so it's related laterally to the backside. See the posterior aspect of the medial surface of the spleen, leaving an impression there. Okay, so this is about the anterior relations of the kidneys. The posterior relations of the kidneys, of course, it's the posterior abdominal wall, but medially, at the medial side, the psoas major is opposite the hilum of the kidney, psoas major, then the quadratus lumborum muscle, then the transversus abdominal muscle on either side, on either kidneys, the right or left. The laterally related to the transversus abdominis, beginning in the middle to the quadratus lumborum muscle, and medially to the psoas major muscle. Here it's showing the quadratus lumborum. There is no psoas major here. And also related to the iliohypogastric nerve and ilioinguinal nerve for both kidneys. But since the left kidney is slightly higher, so it's related also to the subcostal nerve and vessels. So for both kidneys, the iliohypogastric, the ilioinguinal nerves related to the back or the posterior surface of the kidney, but on the left side add the subcostal nerve and vessels, because the left kidney is slightly higher than the right kidney. By putting them in position, you will realize that the right kidney is at the level of rib 12 and slightly in the 11th space. The left kidney reaches the 11th rib. So if we are talking about ribs here and diaphragm eventually, because it rise from the 12th rib, so we are talking about the cosodiaphragmatic recess too of the pleura behind it. So behind the kidney is the diaphragm. At the upper parts, of course, is the diaphragm, separating it from the costodiaphragmatic recess. And this is a major problem when you try to obtain a specimen needle biopsy from the kidney, especially if the patient is obese. You cannot feel that the last rib, so you think the last rib, which is the 11th, is the 12th rib, and you go below it and you think that you cleared the costal margin, or you cleared the 12th rib, but no, you are entering in the 11th space instead, and you are entering eventually into the costodiaphragmatic recess. So please take care in the case of obtaining a needle biopsy of the kidney, and I've seen that. Of course, I've seen it done in the right way, but it's a dangerous procedure if you are not aware of the fact that posterior relation of each kidney is the lower ribs. On the right side is the 12th rib. On the left side, it reaches the 11th rib and may reach the 10th space as well if it's higher than normal. So don't forget this. Okay, so this is the posterior relations of the kidneys. Now, each kidney has a series of coverings on it. The first covering is the renal capsule. The renal capsule, it's part of the kidney, and it does not include the suprarenal gland. This is very important. The suprarenal gland has its own capsule. So the renal capsule does not involve the suprarenal gland. After the capsule, we have a layer of fat called the perinephric fat. This layer, the perinephric fat, this layer, the perinephric fat, right outside of the capsule. And the perinephric fat is thickest at the borders and at the hilum and sinus. And together with the ischiorrectal fat at the sides of the lower rectum and anal canal, it's the last fat to be consumed in the body. Even if the patient lost all of his fat, this fat still remains to keep the kidneys in place. Now, after the perinephric fat, we have the renal fascia. The renal fascia includes the kidney and the suprarenal glands. This is a fact that you should know. And it has anterior and posterior layers. The anterior renal fascia of Ureter, called the anterior renal fascia, continues medially at the hilum and around the vessels, the aorta and inferior vena cava, and it may be continuous with the fascia of the opposite side. And laterally it fuses with the posterior layer and may extend to the transversalis fascia, and above it's continuous with the diaphragmatic fascia, or with the fascia lining the diaphragm. By the way, at the lower part, it may be deficient. The lower pole of the kidney with its perinephric fat may protrude from it, but it's usually complete. The posterior renal fascia, called the Zucker-Candles fascia, continues medially behind the kidney and between it and the quadratus lumborum fascia to the psoas fascia to fuse with it. And laterally, of course, it unites with the anterior layer outside the perinephric fat at the lateral border of the kidney. After that, there is another layer of fat called the paranephric fat. It covers the whole thing, the whole structure, and then the peritoneum plasters all these structures to the posterior abdominal wall. So that's how the kidney is kept in place. And it's worthy of mentioning here that sudden loss of weight, sudden loss of weight, may consume the paranephric fat rapidly, so the kidney might be tilted, and this is a problem in the extreme diets. Take care of extreme diets, that there is a sudden loss of kilograms from the body. The paranephric fat will be consumed and the kidney will be tilted downwards a little bit, and this is dangerous, of course, because it will make a kink in the ureter, and this will obstruct the urine outflow from the renal pelvis. This will produce back pressure on the renal pelvis, a case called hydronephrosis. So don't forget this. Sudden loss of weight has its hazards. It's not completely safe. Okay, this is about the renal coverings. For the structure of each kidney, you have a pale part at the outside. Of course, the renal capsule first, and then a pale part at the outside. This is called the renal cortex, and as you can see here, the cortex extends between these structures, which are called the renal pyramids. This is the medulla of the kidney. Renal pyramids, another pyramid, has a pointed tip called the renal papilla, through which the ducts of Bellini excrete urine into the calyces of the collecting system of the kidney. But don't forget the cortical extensions between the pyramids are called the renal columns. They consist of cortical tissue, and there is a difference between the constituents of the cortex and the medulla. So we have a capsule, we have a pale cortex that has extensions as renal columns between the pyramids, which are the renal medulla. As you can see here, these are the pyramids of the kidney. Okay, now each renal pyramid with the top cortex is called a renal lobe. This is called a renal lobe, and the artery going towards it is called the lobar artery. And between them is the interlobar artery. So the renal lobe consists of a medulla, part of the medulla which is a pyramid, and with the cortex on top. This section here is a renal lobe. If you go further, microscopic structure of the kidney, you will find that it's composed of million units per kidney, units called nephrons. Each nephron is composed of a glomerulus. This is the glomerulus. Coils of arteries made by the blood supply of the kidney. This is an afferent arteriole and this is an efferent arteriole, after forming a glomerular tuft. And this tuft is contacted by a double layer called the Bowman's capsule with the Bowman's space in between. You can see that. And this continues as proximal convoluted tubules. You can see here. From the proximal convoluted tubules extends as the loop of Henle, has a descending thin part and an ascending thick part. This makes a concentration gradient as you go down, then up again. This is made for concentration of urine, and in lower animals that live in hot areas or in the deserts, for example, the urine is concentrated to the extent that the animal may secrete only crystals of urine, and it has a very long loop of Henle to make a bigger and much higher concentration gradient, along which the urine is actually completely gets rid of its fluid component, and what remains is the other constituents of urine as crystals. So the longer the loop, the more concentrated urine you get in a species. After the loop of Henle, you'll get the distal convoluted tubules that open into collecting tubes, or collecting tubules that eventually will form the ducts of Bellini that will open at the summit of the renal papilla. The renal papilla is the tip of the renal pyramid. And as you can see here, the glomerulus, the proximal convoluted tubules, and the distal convoluted tubules are constituents of the cortex, while the loop of Henle and the collecting tubules and the collecting ducts are the constituents of the medulla. See? So there is a difference between the constituents of the cortex, which is this part, and medulla, which is this part. Again, the glomerulus plus the PCT plus the DCT constituents of the cortex, and the loop of Henle and the collecting tubules and ducts of Bellini are the constituents of the medulla or the pyramids of the kidney. This you will be asked about in multiple choice questions. So this is a microscopic picture of the glomerulus to show you here. This is the tuft of capillaries formed by the afferent arteriole that will eventually open into an efferent arteriole. And see, this is the Bowman's space here. This is the Bowman's space that will open into a proximal convoluted tubule. See, the proximal convoluted tubules, the lining cells are bigger and higher than a distal tubule. For example, this is a distal tubule because the lining is thinner. This is a PCT, this is a PCT. This is you see, this is a DCT, distal convoluted tubule, because the cells are slightly smaller or thinner than the cells lining the proximal convoluted tubules. So this is a microscopic structure of the glomerulus, just to demonstrate to you the different components. The blood supply of the kidney, of course, comes from the renal arteries that arise at the level of L2 from the aorta. Has a right and left renal arteries. Which one do you think will be longer? Of course, the right side. the right renal artery will be longer than the left because it must pass the distance of the inferior vena cava, right? It passes behind the inferior vena cava to the right kidney, while the left side and behind the renal vein, of course, um, behind the head of pancreas and the second part of duodenum, which crosses the hilum of the kidney. On the left side, the left renal artery, it's shorter and lower level and pass behind the left renal vein. Don't get confused, by the way, by the levels of the arteries opposite than the kidney itself. So don't confuse yourself with these, fine details. But shorter and longer, it's definite. Pass behind the left renal artery, pass behind the left renal vein, body of pancreas, and the splenic vein, as you can see here. See, this is the left renal vein on its way to the inferior vena cava, and this is the left renal artery. And near the hilum, as you can see here, the artery divides into 4 or 5 branches. But before doing so, it divides into 2 main divisions: anterior division and posterior division. Then subdivide into these branches to supply the kidney, and enter there inside the kidney as the lobar arteries that will subdivide into interlobar and arcuate arteries, as you can we will see in the pattern of supply of the kidney. Also do not forget that the renal arteries supply the suprarenal gland by giving the inferior suprarenal. The suprarenal gland gets its blood supply from superior suprarenal from the inferior phrenic, middle suprarenal from the aorta, and inferior suprarenal from the corresponding renal artery. Do not forget this. The renal artery also supplies the upper part of the ureter by a series of ureteric branches. The pattern of supply, as I told you before, it divides into anterior division and posterior division. The anterior division makes an upward kink and then subdivides to supply both sides of the apex, anterior and posterior parts of the aspects of the apex, and both sides of the lower pole, the anterior and posterior sides of the lower pole, and only the anterior side of the remaining of the kidney. So they subdivided the branches into apical, upper, middle, and lower. But remember that the apical and lower derive from the anterior division, that's 1, and 2, that the apical and lower branches supply both surfaces, the anterior and posterior surfaces, while the posterior division supplies only the remaining part of the kidney, the posterior surface of the kidney, not the apex and not the lower poles. Okay? This is important in the pattern of supply of the renal artery. In an arteriography, in this beautiful arteriography, as you can see here, of course all the branches are superimposed on each other because this is a 2-dimensional view, not a 3-dimensional view. So you cannot differentiate in the middle. You cannot differentiate between the branches of the anterior and posterior divisions, but any branches going to the apex or the lower pole, this means that this comes from the anterior division. See, and this is what you will be asked about. You'll never be asked about branches in the middle because they are superimposed on each other, the anterior on the posterior, because this is bidimensional or 2-dimensional picture or photograph of the arteriography of the kidney. Now, because of this, this radial pattern of supply, if you're doing a partial nephrectomy, you should do or perform radial incisions rather than horizontal or longitudinal incisions to excised part of the kidney. Now the sub-branches are the lobar towards the pyramids of the kidney or the papilla. The lobar is split into interlobar around interlobar between the pyramids of the kidney, and then arcuate artery, then interlobular, that some of them extend to the surface as you can see here, then afferent arteriole, glomerular tuft, and efferent arteriole, and from the efferent arteriole comes out the intertubular capillary plexus and the vasa recta. There is a demonstration to demonstrate that. See, the interlobar artery gives arcuate arteries around the renal pyramids, and as it ascends, it gives the interlobular artery, as you can see here. Branches of the interlobular may reach the surface, called the perforating arteries, that anastomose with the arteries of the capsule. Some of them come back to the medulla, and the afferent artery, then the efferent arteriole. The efferent arteriole gives a plexus of arteries around the descending and ascending loops of Henle, called the vasa recta or arteria recta, and other branches of the efferent arteriole plexus around the PCT and the DCT, called the intertubular capillary plexus. So the efferent arteriole gives off two plexuses, the intertubular capillary plexus around the PCT and DCT, and the vasa recta plexus around the descending and ascending loops of Henle, and of course loops of Henle and the collecting ducts as well, the vasa recta. So any artery you will see as a cut section in the medulla, this belongs to the vasa recta that accompanies the loop and the collecting ducts. Don't forget that. Okay, about the renal veins, a right and left renal vein. Which one do you think is longer? I think is longer. Of course, it's the left one, because it has to travel the distance of the aorta. So the left renal vein is longer than the right renal vein. They open, of course, directly in the inferior vena cava and formed opposite the artery by interlobar and lobar venules that assemble to form the vein at the renal hilum, and then forms the main vein, which travels to the inferior vena cava. As you can see here, it travels in front of the aorta and passing under the origin of the superior mesenteric. So actually the superior mesenteric vessels have a slight pressure on the left renal vein. That's why in physiology, if you ask about the pressure inside the renal veins, the left renal vein has a slightly higher pressure than the right renal vein, because it's pressed upon by the superior mesenteric vessels, as you can see here. It's very evident here. Okay, now there is another difference between the left and right renal veins, in which that the left renal vein receives the suprarenal vein. The suprarenals has only one venous drainage, the suprarenal vein. The left side, because it's away from the inferior vena cava, so it opens into its vein, the left renal vein. And the left gonadal vessels, actually the testicular or ovarian, open also into the left renal vein. And because they open into the left renal vein, they will open into a rather perpendicular angle, right angle. But the right gonadal vessels will come to, as you can see here, will open into the inferior vena cava with an acute angle. Now, perpendicular angle means that more blood will be drawn back into the vein because of gravity. So the pressure inside the left gonadal vessels, especially the testicular one, because it's longer, of course, than the ovarian, so the column of blood will be heavier, and that's why the varicocele is more common on the left side on the left testicle, not the right testicle. Varicocele is more evident on the left side because first, the testicular vein opens in a perpendicular angle, right angle, so the back pressure is more than the right side, and because the pressure inside the left renal vein is already higher because it's pressed upon by the superior mesenteric vessels. Please do not forget these clinical facts about the pressure inside the left renal vein. Okay, the lymphatics is to para-aortic lymph nodes at the site along the vessels, and the innervation by, of course, the aortic plexus gives extension of plexus around the renal arteries, and the detached part of the celiac ganglion called the aorticorenal ganglia or aorticorenal plexus that, remember, in the thorax it receives from the lesser splanchnic nerve, which is sympathetic. So this is the autonomic supply of the kidneys, and of course it goes to the vessels, and by controlling the pressure in the vessels you're controlling the function of the kidneys and excretion of urine, either increase or decrease the excretion of urine. Okay, there is a bunch of renal anomalies like kidneys in the pelvis. They did not ascend as the normal kidney ascends because of the growth of the embryo. The double kidneys, double ureters, or polycystic kidneys, especially if the collecting, that's because the collecting system, the collecting part of the kidney, which are the calyces and the pelvis, are misplaced. They do not open properly, contact properly with the corresponding kidney, or bifid ureters. Each of us could have any. Of course, the polycystic kidney is pathological, but double ureters and bifid ureters may be completely normal. And the horseshoe kidney. Now, the horseshoe kidney means that both kidneys are united at their lower poles. They did not split during development. And because of the growth of the embryo, the kidneys ascend up to take its place in the lumbar region. But I want you to think about this because this is a very tricky question. The horseshoe kidney, while it ascends, where exactly will it stop its ascent? Think about that. Well, it was first in the pelvis, ascends, so passing the bifurcation of the aorta, ascends furthermore, it will be stopped by exactly the inferior mesenteric vessels, the inferior mesenteric artery. The inferior mesenteric artery will arrest the ascent of the horseshoe kidney, and this is a very tricky question that you may be asked in multiple NUR exams. Okay, so this completed this part of the kidneys. Next time we'll be talking about the collecting system of the of both kidneys. I hope you got the maximum benefit from this lecture, and thank you very much for watching.